So now it is my extreme pleasure to introduce Kirsten Oler. She received her BS degree in pharmacy from Ohio Northern University in Ada, Ohio, and a PharmD from University of Toledo. In 1997, she completed a pharmacy practice residency at the University of Illinois at Chicago, and in 98, a pediatric specialty residency at Children's Hospital in Columbus, Ohio. And afterwards, she focused her clinical practice primarily in the neonatal intensive care unit, most recently at the University of Illinois at Chicago, where she's also clinical assistant professor in the Department of Pharmacy Practice. In addition, she serves as the program director of the PGY2 Pediatric Pharmacy Residency and has served as faculty member for the ACCP updates since 2003. And so with that much experience, we know she's going to give us an excellent overview. Thank you.
Thanks, Lisa. Well, good morning, everyone. I will add my welcome to you. While I was happy to wake up in my own bed last year in Chicago, as Dr. Jacoby said, it was snowing there yesterday, so I'm more happy to be here in this weather. So we're starting with pediatrics, where we all began as children. Today, I don't have any conflicts of interest, except I'm a shameless promoter of pediatric pharmacy, so I think you should all be sitting in the room down the hall taking the PEDS course. But since you're here, we'll spend our 1 hour learning everything you need to know about pediatric pharmacy. So to do that, we're going to walk through some cases on neonatal sepsis, pediatric sepsis and meningitis, respiratory syncytial virus infection, otitis media, immunizations, pediatric seizure disorders, and attention deficit hyperactivity disorder. Now, of course, in real life, children experience a lot more diseases than those, and the patients are really more complicated in real life than we have time to discuss in this 1 hour period. But hopefully from these cases, you can kind of glean some of the important pharmacotherapeutic issues that go into decision making when we care for pediatric patients. As a reminder, we will use your audience response cards periodically through this session, so please have those readily available for your use. All right, we'll jump right in with case number 1. This is a neonate who was born prematurely at 36 weeks gestation, develops respiratory distress, hypotension, and mottling at 5 hours of life, has a witnessed seizure in the neonatal intensive care unit, at which time cultures are obtained and the results are currently pending. Of note, in the patient's history, the mother is colonized with group B streptococcus, but she did receive adequate intrapartum prophylaxis before delivery. So from this, we need to decide what the best empiric antibiotic regimen is for this neonate. So to start, we have to consider that this case, the signs and symptoms really do point towards neonatal sepsis. And in a pediatric patient, the diagnosis of rule-out sepsis often comes with an associated diagnosis of rule-out meningitis, especially when we have a presentation that includes such things as seizures. So with that in mind, as we're picking our antibiotic therapy, we want to choose agents that will penetrate the cerebrospinal fluid well, and we also want to make sure the doses are what are typically referred to as meningitic doses. So these are often higher than doses that are used for other indications. So with that in mind, we need to choose between vancomycin, ampicillin and gentamicin, ampicillin and ceftriaxone, or ceftazidime and gentamicin. As with any infectious disease, before we can figure out what our best empiric regimen is, we need to know what the most likely causative organisms are. And in the case of pediatric sepsis and meningitis, these organisms can vary by age. So if we consider this table, we see that our patient falls into this first category, 0 to 1 month of age. And in that category of neonatal sepsis, we can have 2 different types of sepsis. So there's early neonatal sepsis, which happens within the first 72 hours of life. And then there's late neonatal sepsis, which occurs after 72 hours of life. And that's important to consider because that also affects the most common pathogens that we're likely to observe in the patient. So with early neonatal sepsis, the organisms typically come from the maternal genitourinary tract. So we're looking at things like group B streptococcus, E. coli, and listeria, and potentially some viruses, most notably herpes. In late neonatal sepsis, those same organisms can be the cause, but if the patient has been hospitalized in that time, we also have to consider nosocomial pathogens. And in neonates, we're worried about coagulase-negative staphylococcus, gram-negative organisms, as well as fungus. So coming back to our patient, considering these antibiotics, vancomycin for an early presentation, again, we're not really concerned about coagulase-negative staphylococcus yet, so we wouldn't need vancomycin for that coverage. And this regimen doesn't provide the much-needed gram-negative coverage, so that would not be the best option. Ampicillin plus ceftriaxone potentially would cover the most common organisms, but then we have to think about side effects of these agents. And in neonates, the side effect profile of ceftriaxone is a little bit different than in older patients and adults. Ceftriaxone, because of its biliary elimination, can cause biliary sludging, which would decrease the elimination of indirect bilirubin, which can then cross the immature blood-brain barrier and cause kernicterus. So ceftriaxone in a neonate typically is not a good option. Ceftazidime and gentamicin, again here we're lacking the important coverage of listeria and group B streptococcus. Even though the mother received intrapartum prophylaxis because she was colonized for group B streptococcus, and that intervention has been shown to decrease the number of cases of GBS neonatal sepsis, it is still recommended that our empiric regimen account for that organism and cover GBS. So ceftazidime and gentamicin, for that reason, would not be a very good choice. Additionally, for early neonatal sepsis, we really don't need double coverage for gram-negative organisms, so this is a little bit overkill. That leaves us with ampicillin and gentamicin as the best option here. Again, remember, we would want to give this in doses adequate to penetrate the meninges. And to do that, we have to consider some pharmacokinetic differences that we see in the neonatal population compared to older children and adults. So those changes include such things as higher volume of distribution for water-soluble drugs. So typically things like aminoglycosides, we need to administer higher milligram per kilogram doses than we would in the older children or adults. And additionally, there's typically a slower clearance of renally eliminated drugs, especially in preterm babies. So again, our dosing interval would be extended for these types of drugs in neonates as compared to older children and adults. Some of you might be wondering about the regimen ampicillin and cefotaxime. This is often, or at least sometimes, seen in neonatal intensive care units to treat neonatal sepsis. Because of concerns with resistance with routine third-generation cephalosporin use, and because there is some evidence that that regimen is associated with worse outcomes and increased mortality as compared to ampicillin and gentamicin, the regimen of ampicillin and cefotaxime really isn't recommended for empiric coverage of neonatal sepsis. If, on the other hand, we have organisms that grow that warrant those agents, then cefotaxime might be a reasonable choice in this population. So continuing with this patient, our preliminary culture results are now available, and they reveal gram